patient who had triple positivity. Lupus anticoagulant was positive, beta-2 was positive, anticardiolipin was positive, and this lady had come to me with nearly 6 pregnancy losses, and ultimately she got into this very successful 2 pregnancies subsequently, in fact, with low molecular weight, heparin, aspirin, as well as hydroxychloroquine. Now, how do you manage OPS? You got to improve successful birth rate. That's fine. You improved the successful birth rate from 70% to 90% in the population. Very good. Fantastic. Dr. Ramakrishnan is a great fellow. He's got so many people with successful pregnancy loss by treatment. That is not the objective. The objective is to deliver a healthy newborn to the mother. That means you have to reduce pregnancy-related complications like preeclamptic toxemia, IUGR, and prematurity. That's very, very important. You just can't go and say, I treated 100 people out of that, 85 to 90% delivered a child. You know, so many complications are there. You have not done justice. After all, in pregnancy, you have a mother and a fetus, and please respect the fetus also. Objectives: improve the successful birth rate and also decrease the rate of complications with the treatment. Drugs available in the treatment of OPS. Some of the drugs you may be conversant with, some you may not be conversant with, which I shall discuss. Low-dose aspirin, everybody knows. Warfarin, heparin, everybody knows. Antimalarials, some people know. Steroids was known earlier, now it is forgotten. Statins, still of little historical importance. IV gamma globulin, still in the research table. I have not used IV gamma globulin. Plasmapheresis, not used. Rituximab, on the line to be used. Eculizumab is a complement inhibitor which has not come into the Indian market. So let us talk about the common drug, aspirin. Just about 10 paise or 15 paise, low-dose aspirin, 75 to 150 milligrams. It's an anticoagulant because of antiplatelet action. It's a wonderful drug to treat APS, obstetric APS. But more than that, it has got a lot of local effect on the placenta. It improves trophoblast invasion of uterine spiral arteries. It improves the development of the placenta due to its anti-inflammatory effect. No wonder we start low-dose aspirin even in the preconceptional period. That's very, very important. 3 months prior to a lady attempting conception, you can have to start low-dose aspirin 75 milligrams per day in a lady who fulfills the criteria for obstetric antiphospholipid antibody syndrome. That's very, very important. Preconceptional aspirin. Heparin. You see the river is, the brook of Tennyson is flowing very so well. That's because there's no blockade, because you give heparin to a lady with lupus anticoagulant positivity or APS syndrome. The systemic effect is a very good anticoagulant which facilitates the flowing of the blood throughout the body and the uterine spiral arteries, etc., without any blockade. Very good anticoagulant, but heparin has also got a lot of local effects on the placenta. I did tell you that placenta is getting into an immunoinflammatory state due to antiphospholipid antibodies. Heparin blocks activation of complement. It has got anti-inflammatory properties. It reduces generation of inflammatory mediators. It facilitates trophoblastic invasion of the metanal endometrium. It promotes angiogenesis in the placenta. Multiple actions of placenta, multiple actions of heparin on the local side of the placenta is the great hallmark of heparin as far as OAPS is concerned. It is just not a systemic anticoagulant. That's very important. Oh, you have unfractionated heparin and low molecular weight heparin. I will vote only towards low molecular weight heparin. The second important fact, throughout the world, they are using only low molecular weight heparin in the treatment of obstetric APS. Why? Increased bioavailability, once a day usage, lesser incidence of heparin-induced thrombocytopenia, better acceptability, no need to monitor. You can just give prophylactic dose of low molecular weight heparin and keep happy about it. You need not to do APT and all that stuff. More predictable anticoagulant response, therapeutically more effective. So my choice, not my choice, science choice. My choice is nothing. I'm nothing. I'm an idiot. Science choice is that low molecular weight heparin is the drug of choice for anticoagulation and local effect on the placenta. And usually what most of the trials in the world are used only enoxaparin 40 milligrams subcutaneous once a day. That is the standard prophylactic dose in OAPS. That's important. Now coming down to antimalarials. OAPS, the drug of choice is low dose aspirin. The drug of choice is heparin. The drug of choice of heparin is low molecular weight heparin. And I use enoxaparin a lot. Not a lot. I use only enoxaparin. And coming down to mechanism of action of antimalarials. Antimalarials are the wonderful drugs in the treatment of OAPS now. It's a wonderful drug. It's a darling drug of the rheumatologist. Because antimalarials are anti-aggregant. They prevent aggregation of platelets. They are anti-inflammatory effect on the placenta. They are immunomodulatory because APS is an autoimmune condition. It's a darling drug of the rheumatologist now, which is used not only in the preconceptional period, but it is also used subsequent to conception during the pregnant period also. That's very, very important. Wonderful drug of choice is antimalarials. Very, very, very safe medications. Absolutely safe. Antimalarials are very used good combination drug for OAPS, obstetric APS. What drug combination? Low dose aspirin, low molecular weight heparin, enoxaparin, and hydroxychloroquine. I give a cocktail of these three medications, and these come not only from scientific studies, but my experience in nearly 3,500 patients since 1994. It is also useful in refractory OAPS, which I will discuss later. Hydroxychloroquine improves successful birth rate, decreases APS-related pregnancy complications like IUGR, premature labor, or intrauterine growth retardation. It is also used both in preconceptional period and during pregnancy. It's a wonderful discovery drug of this decade for the treatment of obstetric antiphospholipid antibody syndrome and also the vascular antiphospholipid antibody syndrome. It's a wonderful drug. Hydroxychloroquine. It is a drug which made history. It is a drug which lost the battle and was buried alive with respect to COVID. Just because it does not work in COVID scenario, do not take it, do not look down at the drug and say, it's a useless drug. It is very useful in the management of obstetric APS. The dosage is 5 milligram per kg per body weight after food daily. Safe. Conception and preconceptional period and pregnancy, not at all teratogenic. When I prescribe it, some people say, it's teratogenic. It is definitely not teratogenic. The dosage you should usually give is 300 milligram once a day at night or 200 milligram twice a day. Better to take it after food to prevent any nausea. Some people can say hydroxychloroquine, it will affect the retina, it causes blindness. In an absolutely negligible number of people, it will cause. Only before giving hydroxychloroquine, ask the patient whether he has got any pre-existing retinal disease. That's very important. Pre-existing retinal disease is a contraindication to start hydroxychloroquine. No pre-existing retinal disease, just start a hydroxychloroquine and you'll get and definitely the lady goes through a successful pregnancy.